Folks, welcome to Creating New Healthcare. I am super excited to introduce you today to Dr. Scott Conard. I have been a fan of his and a fan of Converging Health, his company, and have had the chance to talk to him and his colleagues numerous times. What they're doing is something that we desperately need in American healthcare. I believe it is a must-have, and yet it's not there, except for what the clients and the customers that Dr. Conard is working with. And that's why I'm sharing it with you all today. I really think this needs to be out there, needs to be known, and needs to be shared by others so that we can actually really help people and really save lives and really prevent the cost of care from continuing to escalate as it is. So let me just ask Scott, Dr. Conard, brief introduction about yourself, and then I want to jump into Converging Health.
Thanks. So I'm a family doctor, been in practice 35 years, still see patients, but now it's down to 5% of my time and not 100%. And my pathway have had several kind of key things in my career. First of all, just being a family doctor, I did a lot of research, was a professor, associate clinical professor at UT Southwestern for 23 years. Then I moved into group management and built a group of 13 doctors that got acquired and became a group of 510 clinicians in North Texas. That had me get an introduction to population health and putting it on the ground and actually having it work. We were 70% primary care. That was bought by a hospital who immediately shut down those efforts because we were, quote unquote, keeping people out of the hospital. So I moved over, started working with broker consultants, Holmes Murphy in Dallas, and then also corporations. And now we have over 110 corporations that Converging Health works with, as well as an insurance company and captives and medical groups. And that's part of my really favorite thing is we work with primary care clinicians and health systems across the United States.
Yeah, I just want to say I know because I've read some of your and your colleagues' work. You've been doing this for a long time. So this is not a flash in the pan. This is not some magical vaporware AI thing. This is tried and true and proven. And again, the fact that you are saving lives and saving money is quite miraculous to me, and it's something we need to get out there. So why don't you share with us the big idea here? What is the problem, and what are you solving for in a new and different way?
As I got involved, as I told you about, with the brokerage consultant firms and the insurance companies as the chief medical officer to try to help and figure out what's going on, I started using the data analytics platforms that were available in the marketplace. And this was 2012. That medical group thing I talked about was 2006 to 2010. So what I discovered when I looked at the data analytics is that they were very powerful from an actuarial perspective, which basically says how much did we spend this last 12 months or last year? What is the health conditions of this population, and what are the trends in the marketplace with regard to inflation, et cetera, et cetera? Okay, we will spend 1.2 or 20% more next year or 8% more, whatever it is. It's a very powerful, very well thought through, very sophisticated model. But as a clinician, it's completely devoid of value because they're looking at a population. I'm trying to look at every single member. So the big idea is that Susan Lindstrom, my partner, and I went through and we created a clinically based uh, analytics process and company. And the process is called Vision Hawk Analytics inside our company, Converging Health. And we are able to create an individual care plan for every person that we receive medical claims, pharmacy claims, eligibility data. We also get EMR data, we get biometrics, we get, from different companies. So we can take anything in, but just based on those three things that are very easily available for, I say very easily, you can get with a little bit of work from corporations in America today, we're able to figure out the population health risk.
Mhm.
And we have created this whole person risk score, which through a lot of sophisticated analytics, Pat Dunn is a PhD who's worked with us on this for 10 years now.
Mhm.
We have been able to predict with a tremendous kind of with an R squared that's three times as high as the actuarial models. Who's going to have an event, a significant clinical event, which is a well-defined event in the next 12 to 24 months? And last concept, when you act, we have been able to reduce catastrophic events in that population, this high risk, low cost population, by up to a third. So, our motto is the best way to manage high cost claimants,
Mhm.
don't have high cost claimants.
Scott, Dr. Conard, this is so important. You're such an expert. I just want to run this back to you in a less expert sort of languaging. So as I understand the problem, because I've worked with populations, and the problem is that up till now, you have people in the population. Up till now, the way to manage costs is once someone has had a hospitalization, once they've had a catastrophic event like a heart attack or a stroke or some major surgical procedure, after that, then the actuaries pick that up. And so we say, well, here's a high risk, high cost individual. Now we're going to treat them. But the problem is the horse is out of the barn. The money's been spent already. And the best we can do is again use statistical up to now, statistical up to you guys, statistical analysis to try to predict who in the population is going to be sick. And so what you've introduced is said, you know what, the best thing to do is not just to capture the people who've already gotten sick, who've already had that catastrophic event. The better thing to do for the individual, for their family, and for whoever is paying the healthcare bills, the employer, the payer, the government, the better thing is to figure out who is going to have a catastrophic event in the next 12 to 24 months and prevent that from happening. Identify them in the population and pull them out and say, hey, Mr. Jones, you appear to be at high risk for something bad happening for you. We're going to grab you and we're going to bring you into primary care and we're going to prevent that from happening. It'll help you, it'll help your family, and it'll help prevent costs for whoever's paying for that healthcare, including you and your family, your employer, the government, etc. Now, the problem with doing that technically is that the data that most of us have used with predictive analytics is non-clinical. And you had the bright idea over a dozen years ago, and I know that to be true because you've published on this, you and your colleagues, you had the bright idea of saying, you know what, the data we get from claims is not enough. We need to add data from the patient's charts, clinical data, and we also have to do something else, which is get more personal data, even like how engaged are they with their own healthcare, which actually is a huge predictor, which you guys, as part of your science, you've discovered. So you're pulling in all these new sources of data, going into the population, and then identifying with a high degree of accuracy, predictive accuracy, who is going to have a catastrophic event. You get those people, you call them up, you bring them into primary care, and you do something unique with them in terms of preventing that. And what that does is help the individual by preventing that catastrophic event. And again, once again, it saves tremendous amounts of money. And by the way, I know this to be true because I've seen your data multiple times, and I think you're going to share some of your most recent data on this. But you not only lower the trajectory, because we know cost of care rising 5, 6, 7, 8, percent a year. You not only lower that trajectory, you can actually reverse it and lower costs, and not 5 years from now, not even 3 years from now, but literally within 12 and 24 months, which, by the way, I have never seen. So I just wanted to sort of restate what you said in less expert language, if you will. First of all, did I get that right? And did I
Yeah,
miss
you,
anything?
you hit the nail. You hit the nail on the head. So let me try to pull that together and just say a couple of key things. First of all, there is a percentage of the population you cannot prevent from having an event. We do what we call kind of a grand rounds or CPC. Dr. Mike Tuggy is my big partner on this, and we will look at the people who go from high risk, low cost to high risk, high cost, and ask the question: could this have been prevented? Consistently, the answer is no in 30% of those events. events. They've got brain cancer, they've got gallbladder, or some other or pancreatic cancer. They somebody ran a stop sign and just drilled them, that they were not doing anything wrong, et cetera, et cetera, et cetera. There's a large number of conditions, we call them lightning strikes, that affect people. The antithesis, the flip side of that is 70% could have. I mean, they're having heart attacks, they're having strokes, they're
Wait. I
getting
just want to, Scott, I just want to stop. So you're saying 70% of the people who are going to have an
who are
event
high cost claimants. No, these are
who are,
now high cost claimants,
yeah, that could have
right?
been prevented.
It could have.
70%. Wow.
Yeah.
I didn't know that. Okay.
When you look at that, it's primary care and prevention is how you'd have done it. Let me give you some quick examples. You've got stage 3, 4 colon, breast, cervical, skin cancer, just as things that are screenable. You've got people who have addictions to alcohol and other things that if they had been in a longitudinal, high quality primary care relationship, there would have been a fighting chance that you would have been able to have them deal with the stress, anxiety, and the things that led to their addiction. We're talking about heart attacks, strokes, kidney failure that come from the hypertension and diabetes. We're talking about diabetes complications. You get the idea. I mean, I could go on. And musculoskeletal things. We're talking about joints that became degenerated that if they had gotten appropriate therapy earlier would not have because of their, the biomechanics of those things. All of those things that we actually, and being a family doctor, and again, I was a professor at UT Southwestern. I had students and residents in my practice for the first 25 years of my practice. Um, you know, it's just like the nose on the front of your face. We could have prevented those things if we had gotten
Wow.
there. So
Scott, can I just want to pause on that because I think that's a really important point. I have heard in meetings, and it's so upsetting. I've heard people, physicians, healthcare leaders say that they're not sure about the value of primary care. And I think, stepping back from what you're doing, I think you are demonstrating in no uncertain terms how important, if primary care is used effectively in a population, how important it is in terms of saving people from having really bad things happen to them. And you're telling me that 70% of those bad things can be prevented with good identification and good primary care.
we're at an inflection point in the United States
Hmm.
with delivering the right kind of care under the right financial model to members of enlightened corporations, ACOs, and medical groups who actually want to change the outcome. And our tool sits right in between those two things. It sits in between the insurance companies, the companies, the captives that are trying to figure out what to do and what resources to bring and what they should pay for and what they shouldn't pay for, and the clinicians who are putting it on the street. So last thing I'll say in that regard is I'm going to tell you about some data from the large corporation in just a moment. But there's a medical group up in Queens, New York called Jamaica. Alan Roth and Luigi Tullo are the primary care leaders of that. They have taken what we've done,
Mhm.
put it in their primary care clinics for a Medicaid risk population, and saved $26 million on total cost of care in 2 years. So this works
Wow.
on both sides because it is a clinically informed model that actually empowers the whole team. It's not just the clinician. It's the pharmacist, it's the mental health clinicians, it's the nurse educators, it's the social workers. That it's a distributed model where it takes the clinical picture, distributes it to the right person on the team. They get delegated authority from the primary care clinician to go do what they need to do. This is what Gino and Alan have done, and as a result, people start getting the right care at the right time at the right place by the right clinician, and the costs go down significantly.
And so Scott, first of all, Scott, I love your passion and enthusiasm. I'm smiling here, and it just it warms my heart because it's just such the right thing for American healthcare. It's what I think is the number one thing we need in American healthcare is access to this type of care. You do so once you use your criteria to and your analytics in any population, you pull in the data and you identify these people who are they're still low cost, but they're high risk and they're going to be high cost in the next 12 to 24 months. And more importantly, they're going to have something bad happen that's in 70% of the time is preventable. You identify those people. You then reach out to them. You bring them into what you call a high value visit, which I love. A high value visit in which you really focus on them as a whole person. You do the real work of primary care. It's a team sport, so it's not just the provider, it's not just the doctor, it's other members of your team, and so it is a high value visit because this is a person who really needs primary care, and
That's
there's
right.
going to be tremendous value out of that visit. And then importantly, as you've taught me in the past, as we've talked about this, the important thing is not just the high value primary care visits, it's everything that happens after that visit. So you and your team have folks, and by the way, anyone can do this, anyone who has primary care and a primary care team, um, then the individual, the patient, the employee, they have to be followed up to make sure that we don't drop them, they don't lose it, they don't forget, et cetera. And making sure that we do the right thing for them and with them. And that leads to 70% of those people that you actually identify, preventing that bad thing from happening and preventing that cost. You have evidence, years of evidence that you can bend the cost curve tremendously, lower the cost of care within a very, very short period of time, and actually even reverse it in the populations that you serve, whether they be employer populations. Could you give us another example of that?
The point of the high value visit is you do a deep dive, a sophisticated care plan that takes into account the mentality of that person, which is the flare risk score that we have, as well as the absolute risk, which is the absolute conditions that they're trying to deal with, including social, personal, biometric, et cetera. And you look at the care quality and you put a comprehensive plan in place and you hand it off. The primary care clinician doesn't do it. They hand it off to a navigator who is accountable to make sure that it is walked out and other members of the team are activated to get it done, including imaging and nurses and everything else. So that is Mike Tuggy, and with his sophistication. And by the way, that works for people who are high cost, high risk, and high cost and low cost. You prevent things with the low cost, but you get people under control. Most people don't realize the high risk, high cost people, 60% of them 18 months later are either dead, they've gone down, or they've gone down to lower cost. And if you're in a commercial population, or they've retired, or they've gone on disability. So there's a lot you can do to the whole high risk population. And that's what, Mike and the groups that he works with, he's got several clinical groups he works with, does. I'm going to circle back now, with your permission, to a large corporation in the United States, because what happened to Susan and I is in 2017 and 2018, we had a large eyeglass company. And every year I'd meet with them and say, here's your risk. And they'd say, okay, what do we need to do? And I'd say, well, here's the different point solutions that we need to address that. And they'd hire another point solution. Well, every time they hired a point solution, the percent engagement of all the point
Mm.
solutions went down. And finally, they're like, Scott, what the heck? This is not working. We need a different solution. So Susan created the personal health assistant program, and that is a program. It is a group of people who are very sophisticated around healthcare literacy, health benefit literacy, and healthcare system literacy that becomes an expert at that company's situation. And then using our analytics, the personal health assistants proactively, and that is like ding, 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 proactively. Everybody here that is listening to that, hear that, because to wait for somebody to make a phone call is a joke, but proactively reaches out.
Mhm.
And because of the flare risk score, which is very sophisticated around the way that person's thinking, that personal health assistant enters the relationship, because this is a relationship, not a transaction, with a what we call a signature. Pat Dunn, the doctor I told you about, has created this model of how do you need to be communicating with this person? Where are they mentally? What's their mentality
Mm.
around their health and their ability to engage effectively? So they establish a relationship. Or so what happened with this company is they said, do something. So
Mhm.
Susan, over the next 18 months, developed the personal health assistant program. We developed the analytics behind it, and it is now deployed in over 300,000 people in the United States, just on that corporate side. Okay,
Mhm.
and so let me give you just real quick highlights.
Yep.
So last year, for a 25,000 member life group, Susan and the Converging Health team of personal health assistants started reaching out proactively to high risk, low cost people. They were able to engage 52% of the people that were on the list at the beginning of the year. They needed to engage, and here's the results. There was a 10% improvement in their total health, meaning that their whole person risk score went down 10 points, which implies that they have improved their health by 10%, and the costs for those people are down 18%
Mm.
in 1 year, with engagement from these non clinicians. They are not practicing medicine. They don't make the music, they make the music sound better. They don't practice healthcare, they make the healthcare system functional. And they're engaging people with primary care. That's number one. Two, with the best specialists. Three, with the other pathways of care that this large company had worked out. And so we're talking about a $9.1 million reduction in cost for this group of people relative to what those costs would have been if they had not engaged with a personal health assistant. And I can go over the numbers with that when we have time, but I've got $9,120,659.85 is what the actual cost reduction was in this group of people. So
And how large was that population? How large was that employer?
So the whole population of the company was the whole population of the company was 25,000. And when you look at the high risk individuals, the high risk individuals, let me give you the exact number, that were on the plan at some point
Hmm.
in 2025 was 16,458. So the
That's amazing.
so those are the actual numbers. I have them all right in front of me right now.
That's great. That's
And
great.
so it's a
I,
big company, but we've
yeah.
done this for a manufacturing company that is in rural America that has 1,200 people. Their trend has been flat or negative, had been flat or negative for 7 straight years. Last year it went up slightly, but when you look at the 8 years together, they're 36% below the cost if they had trended with their community. So
Mm.
I think that if you're not seeing a reduction in the health benefit costs, if you're a corporation or if you're an ACO or a healthcare group or a big primary care group that's taking a lot of risk, if you're not seeing a negative reduction, it's just because the systems are immature. And if you get the right information and data and grow the system, it takes 18 months to get a system to really
Yeah.
function well.
Yeah.
You can save lives and save a tremendous amount of money.
Yeah. I think what I hear a lot from folks is, hey, we've done predictive analytics. It doesn't work. It's not that effective. I think the difference here is, and it's really, really encouraging. The difference here is that you are bringing in data, clinical data, and more importantly, you're bringing in, yes, yes, social data as well, but you're bringing in the person. And I really love that you're looking at the individual and saying a person is not just their clinical, it's not just their claims, it's not even just their social factors. It's who they are as a person. Are they engaged? Do they, and that's God, it's really bringing the humanity back into healthcare. It's a little bit back to the future, and the fact that you've taken that and actually quantified that and made that part of your analytics and your predictive capabilities. See, I think that's the difference. I think that's your secret sauce, and no wonder you're seeing better predictive analytics than anything I've heard of before. No wonder you're seeing the cost curve bend and savings that like I've never seen before from this sort of predictive analytics. So, Scott, I know we have to wrap up here, but just want to thank you. Converging Health, people can go to your website, check it out. Super excited about what you're doing, the direction you're taking this, and more importantly, I'm super excited about the fact that you're really saving lives, and it's really, really important. So thank you for the work. Thank you and your colleagues for the work you're doing.
Yeah, thanks. The highest compliment I ever got was from the president of Hilti Tools, who I'm the medical advisor to them. And he said, my legacy was to build our company to, this financial number. I won't say it because it's probably not public, during my career. And I achieved that. He said, but the biggest thing that I'm going to retire with is you've been able to show me the number of people that would have had an event that didn't. I have people walking in my office that tell me that I saved their life. The president of a business, saved their life. I never went into healthcare, but I've had people drive across the country to thank me for
Wow.
our health benefit program. And I was like, dude, you just made my entire career. Thank you.
Wow. That's all we have to say. Thank you, Scott. Really, really thank you for what you're doing.